This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026, titled The Fundal Cerebrospinal Fluid Cap in Vestibular Schwannoma Surgery, a predictor of outcome after the retrosigmoid approach.
This is a topic that hits home for those of us spending long hours in the posterior fossa. We're always looking for better preoperative indicators to tell us, and more importantly, to tell our patients what to expect when we wake them up. We've always looked at tumor size and Coues grade, but the fundal cap is becoming a major player in our surgical planning. Ilara, for the residents listening, let's start with the basics. What exactly are we looking at on the MRI?
Right. So the fundal CSF cap is a radiological finding that correlates to a pocket of cerebrospinal fluid located lateral to the vestibular schwannoma, right in the fundus of the internal acoustic meatus. On your preoperative MRI, specifically on the T2 weighted sequences, or CIS or Fiesta sequences, you'll see it as a volume of high T2 signal at that lateralmost aspect of the meatus.
And anatomically, that's not just a random gap. The paper explains why this fluid is so significant for our dissection planes.
Exactly. Vestibular schwannomas grow within the arachnoid pocket of the vestibular nerves. They tend to preserve an arachnoid plane medially on the outer arachnoid wall of the CP angle cistern, but they also maintain a plane laterally within the meatal arachnoid. The authors note that the fundal cap CSF space essentially defines the lateral aspect of that tumor arachnoid pocket. This is crucial because it provides an undisturbed starting point to define the perineural dissection plane. It allows us to identify the plane off the facial and cochlear nerves from lateral to medial.
That's a key point. If the tumor is completely filling the fundus, meaning no cap, we're often flying blind at the most distal point of the internal auditory canal. This study is a systematic review and meta-analysis. Walk us through the scope of their data.
They conducted a very comprehensive search through March 2025. They included 17 studies, which gave them a total pool of 2,370 patients. They were looking at 3 primary outcomes: facial nerve function, hearing preservation, and the extent of resection, all stratified by whether a fundal cap was present or absent.
Now, the meat of the paper is in the odds ratios. Let's talk about the facial nerve first, because that's often the patient's #1 concern. What did they find regarding House-Brackman scores?
This was perhaps the most striking finding. For patients undergoing a retrosigmoid approach, the presence of a fundal cap was associated with a significantly higher rate of good facial nerve outcome, defined as HB grade 1 or 2. The odds ratio was 6.04.
6 times more likely to have an HB1 or 2? That's massive. In the world of surgical statistics, an OR of 6 is rare.
It is. However, there's a catch. This predictive value was specifically significant for the retrosigmoid approach. When they looked at the translabyrinthine and middle fossa approaches, the association didn't reach statistical significance.
That actually makes a lot of sense if you think about the surgical corridor. In a retrosigmoid approach, we're coming from medial to lateral, but we're limited by how much of the posterior wall of the internal auditory canal we can drill before we hit the labyrinth. If there's a CSF cap, the tumor hasn't reached the very end of the canal, so we don't have to dig as deep into the fundus, where the facial nerve is often most splayed and vulnerable.
Exactly. The paper suggests that the anatomical considerations of each approach play a role in why the cap matters more for retrosigmoid surgery. In translabyrinthine or middle fossa approaches, your exposure of the fundus is more direct from the start, so maybe the cushion of the CSF cap is less of a factor in protecting the nerve during those maneuvers.
Let's move to hearing preservation. For our patients with serviceable hearing, AAO class A or B, did the fundal cap offer the same kind of hope?
It did. Again, focusing on the retrosigmoid approach, the presence of a fundal cap was associated with an increased rate of hearing preservation, with an odds ratio of 3.37. Interestingly, they also checked the middle fossa approach for hearing, but the RR there was only 1.47 and was not statistically significant.
Again, it points back to that lateral to medial dissection. If you have that CSF cap, you can identify the cochlear nerve and the plane of the tumor more easily at the fundus. If the tumor is plugged into the fundus, the mechanical stress on the cochlear nerve and the internal auditory artery during those final stages of tumor delivery is much higher.
They even mentioned radiosurgery, which I found interesting. Even though it's not a dissection issue, a fundal cap is still predictive of hearing preservation after radiosurgery. It might be a proxy for a smaller tumor volume or just less compression of the neural structures in the confined space of the canal.
Now, what about the extent of resection? Surgeons often worry that if they're too conservative to save the nerve, they'll leave too much tumor behind.
The data actually showed the opposite. The presence of a fundal cap was associated with an increased rate of gross total resection, or GTR, with an odds ratio of 2.13.
So if you have a cap, you're twice as likely to get it all out, and you're more likely to save the facial nerve. It really highlights how much the ease of the arachnoid plane dictates the entire case. If the plane is there, everything goes better. If the tumor is adherent or filling every nook and cranny of the fundus, you're fighting for every millimeter.
We should mention the limitations. The authors did note that the included studies were generally at a high risk of bias. They used the Robbins IV2 scale for assessment. So while the numbers are compelling, we have to remember these aren't randomized controlled trials.
True, but in neurosurgery, we rarely get those for specific radiological signs. This meta-analysis of over 2,000 patients is likely the best evidence we're going to have for a while. So, Ilara, how does this change what you're doing in the clinic on Monday when you're seeing a 45-year-old with a 1.5 centimeter vestibular schwannoma?
It changes the nuance of the counseling. If I see a clear fundal CSF cap on the T2 or CIS, I can be more confident in telling the patient that our chances of preserving their facial nerve and hearing via a retrosigmoid approach are statistically much higher. Conversely, if that tumor is wedged into the fundus with no cap, I'm going to be much more cautious. I'll tell them that the dissection might be more difficult at the lateral end and the risk to the nerve is higher.
Exactly. It helps manage expectations. It also might sway your approach choice. If there's no cap and hearing is already borderline, you might lean more towards a translabyrinthine approach if you feel the retrosigmoid won't give you the lateral access you need to safely peel the tumor off the nerve in a crowded fundus.
The paper is very clear in its conclusion. The presence or absence of a fundal cap should be documented preoperatively. It's a simple radiological sign, but it has profound implications for risk assessment.
It's one of those things that once you start looking for it, you can't unsee it. It becomes a central part of your mental map of the internal auditory canal. Any final takeaways from the study?
Just the reminder that the fundal cap isn't just about space, it's about the arachnoid. That CSF represents a preserved arachnoid plane that acts as your safety net. As the authors put it, it's that undisturbed starting point for the perineural dissection.
Well, this has been a great deep dive. For our listeners, residents and attendings alike, take a second look at those T2 sequences on your next acoustic case. Look for that high signal cap in the fundus. It might just be the most important 6 millimeters of the whole surgery. Thanks for joining us today on the Neurosurgery Hub podcast. We'll see you next time.